Okay, so let's take a look at some of the criteria that we're going to start to use as far as looking at an EKG strip. Some of you already should have. We printed out 4 of these yesterday. So look at what we're looking for. There are some rules, so we're going to follow this as a linear fashion when we start looking at EKG rhythms. So what we should see is that there's a P wave. When we have a tracing, we should notice that there's a P wave for each P wave. These P waves seem to have the same distance between them. P wave is usually upright. It's before a QRS complex. It's not very wide or large. We should see small little pause just before that. We know that's called a PR interval. The PR interval is pretty short. If it gets really wide, then we want to bring that up. But usually it's very short. Remember I told you the P wave is present, the PRI is short. Hardly noticeable, QRS complex can be wide or narrow, but we have a QRS complex. And this is mostly upright, so this is a positive deflection. It can be narrow, it can go up and down. You can see obvious signs. But this is the QRS complex, and in between these areas, these should actually march out. They should be equal distance. From one complex to the next, they should be equal distance. In fact, because this sinus rhythm is so regular, that if we were to measure the QRS complex and then measure this P to P interval, it would be the exact same. So, we'll then continue on and make sure that we have a T wave that looks the same following every QRS complex. So we're just following down these rules that we have a P wave, there's a PR interval that is short, we have a QRS complex, this could be narrow or wide, and then we have a T wave preceding that. Again, we're gonna then measure out these P waves to make sure that the P to P is exactly the same from one complex to the other. The entire complex, remember, is a P, QRS, and T. This entire thing is one. So you need to measure from here to here. Now, if you start wandering around and you start thinking that this might be a P wave, go ahead, try to measure it out, see if it comes out. More than likely it won't, just because that's just how it is. This is one complex, this is the next complex, this is the next one here. So as we go over these strips, we have some criteria to rule out. Again, it follows this linear process. That's the first thing. As we go through it, then we measure this P to P interval. So P to P. And then we have, what wave is this? If we go upward, the positive deflection, the first negative deflection would be a Q. A positive deflection from baseline would be an R. And a negative deflection below that would be an S. So it doesn't matter which deflection you're taking, you can use this part of what looks like to be no Q, but it's part of that R wave. You could use this little S wave if you wanted. You can measure from here to here to here, however you want, but we're gonna say this R to R is gonna be exactly the same. So that when we measure this, we have the same measurement. When we measure this, we have the same measurement. Now, because we're trying to figure out, well, what are we measuring it to? We just using some type of marker that shows that when I put a piece of paper down and I put a dot here and a dot here, when I move that dots over, it'll line exactly back up to where we have the next P. You don't need to have a specific type of ruler to rule this thing out, to measure. So any blank piece of paper you can use as you look at an EKG strip. The same thing occurs with the R to R. And if this is a sinus rhythm, you'll note that the R to R intervals are the same as the P to P interval. And therefore we have not only all the criteria that we met, all the P's, we have a PR interval, we have a QRS, and we have a T. The R to R's and P to P, these rates will be identical as well. So when we measure this out, using the 6-second strip, if this was within the first 3 seconds, we would have 3 beats. We add another 3 beats in the next 3 seconds, we'd have 6 beats. This means that the ventricular rate is 60. 60, ventricular rate of 60. We also know then the atrial rate is also 60. That's important to know because the atria are emptying into the ventricles, allowing the ventricles to enlarge with a little extra stretch, so that when they compress and contract, that we have more of a stroke volume that goes up in the ventricles. Again, the T wave is just repolarization. And we would call this a sinus rhythm with an overall, if we're looking at the overall 6 seconds, overall rate of 60. It's the sinus rhythm with an overall rate of 60. Now we did talk about something coming early. And we talked about it being early here for atrial contraction or premature atrial contraction. What we're going to focus on is just the PAC. I'm going to leave this junctional thing out as we're just learning the basics. We don't want to confuse everybody, but we do have what's called a narrow and an early premature beat. So the PAC is a narrow QRS complex. Right? And it's because it's coming from above the ventricles, and the energy that it travels down, this conduction pathway or wires within the heart, allow it to stay in a narrow complex. So what we'll end up seeing is you'll still see somewhat of a P wave, a narrow QRS complex, and a T wave, but it's just a narrow complex. And if it originates from the ventricles and it comes early, it's called a premature ventricular complex. And as a result of this, we might not have a P wave. What we might see is just a type of widened QRS complex. And it's wide, and it's just, when we look at it, it doesn't look like the normal sinus beat that we've been looking at. And that's basically what we're trying to figure out at basic cardiology, is to understand what the normal basic rhythms look like. And anything abnormally wide, let's wonder if that's coming from the ventricles and it originated in the ventricles. All right, so the last thing as we look at these, and we're doing these criteria, and we have an early beat, either wide or narrow. The last thing to say about these differentiating between the early beats. One early beat will have a pulse that coincides with this contraction of the QRS complex, and the other one may not have a pulse. The one that probably will have a pulse, more than likely, is the atrial one, because it's firing from up in the the atria. It's causing the ventricles to depolarize, and what happens is it allows the atria to then fill and pre-fill the ventricles. So you should have a earlier filling, and you should have an early beat when you feel for a pulse. So every time this irregularity comes on, and let's throw it an early narrow beat here. And I drew it here like this because you're looking for a P wave, and what you won't see is that sometimes this P wave is hidden in this T wave. This happens that way. But this earlier beat, the spacing here, because it came from the atria, probably have a pulse originating with it. I'm going to erase this one, and we're going to draw up our ventricular contraction. When the ventricular contraction occurs, here you have that R to R criteria. This R to R is not as wide as this R to R here. So when we measure this, we can tell that it came early because these seem to be regular, but this one came really early. And it's wide. Tried to draw it in this orange fashion. Again, it's not always color-coded as we are drawing on the board, but here we don't have that normal configuration. When it's wide like this, it doesn't allow the ventricles a lot of time to fill up. And so with that electrical impulse, even though it may cause a contraction, it may not have enough blood volume within it to cause the pulse to be felt. So stroke volume within there is too little for you to feel actually a strong carotid pulse. So it may or may not have a pulse. Depending on how many of these are occurring, you may feel a pulse, 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 no pulse. And then it may continue and you'll feel pulse, 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 no pulse. So ventricular ones may not have a pulse because it doesn't allow the ventricles to fill, and the stroke volume that's in there, the preload, it's allowed to fill is inadequate to generate a pulse when the ventricle contracts. Again, these are just premature beats. What we want to basically know, basic cardiology, is that we're looking for P, PRI, QRS, and T. We're knowing that the P wave is early. It's before every complex. There's a PRI interval. This P wave is usually upright. It's not very large. The PRI interval is usually short, very unnoticeable. There's a QRS complex. The QRS complex can be narrow or wide, and then there's a T wave. And these things march out. They're very regular all the time. The P's and the R to R's here, they measure out exactly identically the same. The only weird thing is when we're looking at these, we may have an early beat, either ventricular, which is wide, that's depicted here, or a narrow complex that originated in the atria. And it's just something that's sometimes a normal variant, or it may be contributing to a medical condition that they're being suffering from. So it's just something, when we're looking at this, we want to be able to identify it and just bring it up to our LS provider. Again, if we were to measure this out, if this was our first 3-second strip, and I were to put this now, copy this exact item and place this on the other 3-second strip, I would have a 1, 2, 3, 4, 5, 6, 7, 8. 8. I have a sinus rhythm with 2 of these wide PVCs or ventricular ectopy at an overall rate of 80. So now they would say, okay, you have 2 ventricular ectopy and it's considered part of the 80. So that means you would have 6 of these, 2 of those. Now the configuration, when you see it, it could be like 2 on 2, like this wide one, 1, 2, 3, 4, then a wide one and 1, 2. So it can change, but overall we're having 6 of these and 2 of those. Overall rate. So it's not the best, but it's an overall rate. All right, just for the dog and pony part, if we were to take this exact picture and place it over here, 1, 2, 3, this PVC, 1, 2, 3, PVC, and we continued this cycle, 1, 2, 3, the 4th is a ventricular ectopy. So we would end up calling this a special type of rhythm. The first, if it were after each one, it would be bigeminy. So if it was like here, this beat, this beat, this beat, and I took this and I went this beat, right? Narrow, wide, every other one is bigeminy. The third one is trigeminy. The 4th one would be quadgeminy. All right, so the more frequent you have these PVCs, it becomes problematic, and we worry more about these than we do those. The only reason why is that this one usually generates no cardiac output, or the stroke volume is so poor that we don't have a pulse. So if we think about it, if I were to erase this, and this is occurring over and over, this is occurring over and over, or even if this was your 3-second strip, 3 seconds here, and we then replace this and put 2 more on this side, what's the overall heart rate here? 1, 2, 3, 4. We put 1, 2, 3, 4. We have a sinus rhythm with an overall rate of 80, but we have 1, 2, 3, 4 ventricular ectopy. So what they're going to end up reading is like, well, wait, there's an overall rate of 80, so they have 8 complexes, and we have 4 of those that we took half away, half, that don't generate a pulse, and we wonder why our patient now is feeling lightheaded, faint, and can't stand. It's because these have very little stroke volume when they cause this contraction, and there's no pulse felt. So they're bradycardic, really. When you feel the pulse, you'll feel a pulse deficit, because you'll feel the black complexes, the sinus complexes, the ones that you can have a pulse felt with them. And then you have no pulse, because I just told you there's no stroke volume. With ventricular, or the premature ventricular complex, so you're not feeling a pulse. So again, when you're looking at the rhythm and you're trying to determine, look at the patient. Check to feel every beat with those complexes as you see it go across this EKG screen. And if it's a wide one and it has no pulse, you pretty much determine that I think this might be a ventricular in nature. But more of these will cause the person to be lightheaded and faint.